You're listening to Nitty Gritty Nursing with Nurse M, where she breaks down the nitty gritty basics of nursing concepts. All right, hey there, and welcome back to the Nitty Gritty Nursing Podcast. I'm on the road currently, so if you hear any weird background noise for this particular episode, it's probably from the hotel that I'm currently in at a conference. Today, we're going to unpack a condition that nurses in acute and critical care should really know about, and that is Guillain-Barré syndrome, or GBS, which is another way that you will probably hear it referred to. It's a rapidly progressing disorder that can lead to paralysis, but with the right interventions, patients can actually make a full recovery. So let's get into the nitty-gritty basics and like deep dive of what the pathophysiology, the presentation, interventions, and evaluation and education, everything that you need to know, basically, if you're going to be working at the bedside, dealing with these sorts of patients. Now, from a pathophysiologic perspective, Guillain-Barré syndrome is an acute infectious autoimmune disorder that affects the cranial and peripheral nerves. Now, this syndrome typically occurs a few days to weeks after some sort of viral or bacterial infection, which usually is actually from or post a mild upper respiratory infection or some sort of gastroenteritis. And interestingly enough, here's your weird, interesting fact of the day as it relates to Guillain-Barré, but it is most commonly caused by a Campylobacter jejuni bacterium, which is a foodborne illness and is commonly found in poultry, raw milk, and untreated water. Now, if someone has the unfortunate experience of getting this particular bacterium, for example, what they end up having is gastroenteritis symptoms. So they end up having cramping, diarrhea, abdominal pain, and it usually clears on its own, typically within about a week, unless the person gets more serious complications down the road, like Guillain-Barré syndrome, which is what we're all here to talk about, what you're here to listen about, as I kind of, talk about the nitty-gritty components as it relates to nursing. Now, in terms of the pathology, when someone gets sick with either a viral or a bacterial infection, the body's immune system responds and mistakenly attacks the peripheral nerves, leading to inflammation and damage to the nerve coverings, which we call the myelin sheaths. And this is specific to Guillain-Barré syndrome, right? So someone gets sick, and then once they have recovered from that illness, their body's own immune system reacts to itself. This demyelination that occurs disrupts the nerve's ability to conduct or correctly pass signals back and forth, and as a result, the person begins to experience weakness, sensory loss, and even paralysis that starts in the legs, or starts in the periphery, I should say, and moves upward or inward, and this is called ascending paralysis. Now, if we understand that the demyelination of the nerve sheaths results from this immune system overreaction and someone has ascending paralysis, normally these patients seek help sooner rather than later, because even if it were me, I would be concerned if I was slowly losing my ability to feel my feet and it was sort of progressing up my legs, or if I couldn't feel my fingers, or I had terrible nerve pain and it was progressing inward. It's probably not a problem that I'm just going to sit on and ponder about at the end of the day. But in really, really severe cases, individuals that end up developing Guillain-Barré after some sort of infection, and if they let it progress, it affects the diaphragm, which is that muscle that is responsible for breathing, and that then, in effect, can lead to respiratory failure. And that's when things get really critical really fast, which is why, as nurses or future nurses, if you're a nursing student, you want to understand what the risks are associated with Guillain-Barré and how does this even show up, and how would you even know to catch it? So if we go back, and we're going to tie it back to that pie analogy, how do patients present? What interventions do we do? How do we evaluate and educate? So the patient presentation right out of the gate. How does Guillain-Barré syndrome show up? Patients will actually often come in reporting some sort of peripheral nerve or weakness problem, and they will tell you, or they will report that they had a recent infection, usually within 1 to 3 weeks prior to them arriving, and it's normally some sort of upper respiratory infection, or URI is how you may hear it referred to as well, or gastroenteritis that they've had, and and have seemingly recovered from or are at the tail end of getting over that sort of sickness. And what they really start to complain about is tingling or numbness in their feet and in their legs or in their hands. And this can also manifest just as pain or even like a super hypersensitivity. So they'll say, like when I go to bed at night, just even having the weight of things like the bed sheet that is on their bed causes terrible like pain in their hands or their feet or in their periphery. And it will progress, and it progresses to a muscle weakness that moves upward. And this will even include like the progression if it is allowed, or if we don't catch it or intervene, or they don't seek help. It can even then cause progressive weakness of facial muscles. They will also start to experience weird difficulty with walking, their ability to climb stairs or grip objects, like picking up a can of a soda or a beverage. Like the gripping of those objects will become much more challenging. And downstream, if we let this condition go, in really severe cases, they will experience respiratory distress and even difficulty swallowing or speaking. So from a nursing perspective, in terms of that patient presentation, what we're looking for is the physical signs we're assessing for are muscle weakness that gets progressively more and more weak over hours or even days. They will have absent or decreased deep tendon reflexes, again, because remember and go back to what is actually happening in Guillain-Barré syndrome. That person has just suffered and recovered from some sort of illness, whether that was a URI, whether that was gastroenteritis, whatever. And in that process, their own immune system starts to go haywire and starts attacking itself. And it's not just attacking itself, it is specifically attacking the nerves and destroying those myelin sheaths that are covering the nerves that allow the impulses to be sent. So we end up with not having very good reflexes as well, because the nerves cannot conduct that. They will also end up with facial weakness, or they'll have almost like a Bell's palsy-like appearance bilaterally. And Bell's palsy is where, you have a virus, right, that affects part of the facial nerves, and they actually come in, and we often think that they are strokes because they are unable to move part of their face because of the inflammation that is occurring around the nerves that control the facial muscles. They could also, in theory, though, have autonomic-like symptoms, and that autonomic nervous system is the fight or flight system. So we'll start to see potentially fluctuating blood pressures, potentially cardiac dysrhythmias or urinary retention. And what we're really watching for with patients who have Guillain-Barré syndrome is we're watching their respiratory rate and effort, we're watching their O2 saturation, because we are really concerned, right, about their ability to carry on normal physiologic habits like breathing and maintaining their blood pressure because of the pulse irregularities, especially if the autonomic system, right, because those are all nerves, it goes on the fritz, and we'll start to see sudden swings in blood pressure. So if you think big perspective about the presentation of these patients, what you're going to find in your assessment is progressive weakness, progressive like sensory disturbances or changes in how they are feeling in their extremities, and it goes upward. And so we have that ascending paralysis. Now, in terms of interventions, care is really directed at treating the symptoms, which includes pain management, because if you've ever had nerve pain, or if you know anyone in your life who has ever had nerve pain, it is some of the most unrelenting pain, and it is very difficult to control. And let me be very clear, in Guillain-Barré, there is not a cure for this. And there's not a cure because this is an autoimmune issue, meaning, again, that the patient's own immune system is attacking their own nerves. It's an autoimmune problem, and to that end, we are truly just left with symptom management and making sure that they continue to breathe. So where the crux of a lot of this information and nursing care is derived from is really in the interventions, because we can't stop them from getting, Guillain-Barré syndrome if their own immune system decides to turn on itself and start attacking their own nerves or nerve coverings, those myelin sheaths. So we talk about respiratory system, and we're going to monitor their respiratory rate, everything respiratory. We're assessing for signs that they're going to show for respiratory failure, because the nerves that are innervated, even in the diaphragm, will become weaker over time. And as they become weaker, those triggers to breathe autonomically or automatically, let me see what I did there, autonomically, because it's the autonomic system, they are going to weaken. And as they weaken, the patient will then not be able to take really deep breaths. And because they cannot take really deep breaths, right, we are also monitoring their vital lung capacity, meaning we want to keep an eye on the amount of air that they can inhale and exhale, because that is a correlation that we can use with their thoracic musculature and their diaphragm that allows us to understand how much they're breathing in and breathing out. And if you are worried about their ability to breathe because you are concerned that they are going to become progressively more and more weak, what happens when we become progressively more and more weak? In our respiratory system, we kind of just stop breathing entirely. If the muscles can't do their job because the nerves are affected, we don't breathe. And so we want to be prepared for the worst in the realm of anticipatory thinking, which means that if we're worried about that potential, that they're not going to be able to breathe effectively, then we need to be prepared to breathe for them. And we do that via like intubation and mechanical ventilation if needed. The second, that's the first big priority in terms of interventions. It has everything to do with respirations. We want to make sure that they are breathing effectively, and if they are not, what are we going to do to help manage that? And at the end of the day, it is going to be ensuring adequate respirations and ventilation. The second big priority is all about preventing complications. And there's two components to this. So we want to monitor, right, in terms of complications, we want to monitor for autonomic instability, or that fight or flight system being activated because of the nerves being unable to send signals. And we know that in the fight and flight mode, we increase our blood pressure through the peripheral vasoconstriction to redirect blood to key organs, or to shunt it back towards the core. And in doing so, we increase our blood pressure, and so when we're increasing that blood pressure, we need to watch for changes in what their blood pressure is actually doing, because if it suddenly skyrockets, we need to be able to intervene. And because these patients, right, are potentially losing the ability to walk with their muscles that are becoming progressively more and more weak, we want to try and prevent any sort of complications from that immobility that they have the potential to develop. So, for example, if we just think about what sorts of problems results in patients who are immobile and they can't get out of bed, what are some of the things that first come to mind? For me, the big one is if you can't move and you're stuck in a hospital bed, I'm worried about clots developing, or DVTs. So DVTs can form, pressure ulcers can form. If they're really immobile, they can develop contractures, just to name a few of the problems as it relates to immobility. We take the component of mobility for granted, and we really shouldn't, because being physically active is such a huge component of staying healthy. At the end of the day, though, we want to prevent DVTs from forming and make sure that they're going to get, right, some sort of DVT prophylaxis, whether that is applying sequential compression devices. You may also hear these referred to as SCUDs, or giving some sort of like low molecular weight heparin or anticoagulant to prevent a DVT from forming. That lack of movement also means, right, that the patients are at higher risk for pressure injuries. So turning them every 2 hours will kind of help prevent this, especially shifting the pressure away from certain skin or bony prominence areas is very important. And the third thing, right, that I mentioned about the contractures, to reduce that reduced range of motion that they are not actively engaging with, means that they have a higher likelihood of developing contractures. And so we want to help facilitate the range of motion exercises to prevent the contractures as best as we can. Now, in terms of the interventions of how do we even treat this? Well, I've already told you that there's no cure because it is an autoimmune issue. And so the goal is to sort of facilitate a rapid resolvement of this problem. And one of the ways that we do that is through direct medications based on immunotherapy. And there's two big components here. So as nurses, we would probably administer IVIG, or we would, facilitate the patient receiving plasmapheresis as ordered. And these can help reduce the immune attack that is currently underway when someone develops, Guillain-Barré syndrome. Now, IVIG specifically is short for intravenous immunoglobulin and is a form of immunotherapy used in autoimmune problems, which is what Guillain-Barré is. The idea behind IVIG is that a healthy donor donates their blood, and it is just donated immune system antibodies from someone. And by giving a patient who has GBS donated antibodies that are healthy, it provides a boost or bump in extra antibodies that are not attacking that person's own body to help reduce the severity of illness. Because essentially in Guillain-Barré syndrome, the person's own immune system, again, is attacking their body's own nerves and causing inflammation and damage. And so IVIG can help regulate the system and reduce the severity of those attacks. Now, plasmapheresis is a procedure where a machine is used to separate out the plasma, which is just that liquid part of the blood, from the blood cells, and then the blood cells are mixed back in with a replacement liquid and returned back to the patient. But by removing the patient's own plasma, it removes any harmful substances that they have in their plasma, like the antibodies that are actively attacking their own body and nerves in the whole system. So we can do those two big things. We can do IVIG immunotherapy infusions, and the patient can go through plasmapheresis. Those are really your only two options for treatment-based parameters in Guillain-Barré syndrome because it is an autoimmune disorder. The other consideration, just from a nursing perspective, is we want to keep nutrition and their capacity to swallow in view, because a swallow evaluation, especially if the muscles in the head and neck are involved, those are all responsible for swallowing, speaking, and chewing. And if we cannot consume calories, protein, those building blocks to help repair the system, it extends and makes the recovery process so much longer. And if that happens, then we really have to start to consider some sort of enteral nutrition if needed. At the end of the day, though, right, evaluation and education, we're looking to see, is the respiratory status stable or improving? Are their muscle strength and reflexes returning? Did we prevent any complications that we could anticipate, like DVTs or pressure injuries? And is their autonomic function stabilizing, meaning their blood pressure and heart rate? In terms of education, at the end of the day, we do try to reassure patients that most people fully recover from Guillain-Barré syndrome if they develop it, but it can take months or even years, depending on the severity of the condition that the person had and the supportive care that they were able to get. We know that depending on the systems where patients are located or the communities in which they live, that they may not have access to a level 2 or a level 1 trauma center or a specialized care center that has the immunotherapy, or they might have to travel an extended distance compared to others that might be located or live within a community that has access to those resources. So that is just one of those things that if your patient has Guillain-Barré syndrome, they're likely to end up in some sort of care center that can provide some of these services to help expedite or, support their care and recovery as this autoimmune disorder runs its course. And we really want to try to help explain and clarify timing of treatments like IVIG and plasmapheresis. For example, IVIG is an infusion of healthy donor antibodies to help sort of fix the problem because the patient's own antibodies are attacking their nerves. And plasmapheresis involves a machine that separates the patient's plasma and blood cells to remove the antibodies in the plasma that are attacking their nerves, and their blood cells are put back into them with just another plasma replacement solution. And then, they get returned to that patient. So these patients also often experience terrible, terrible nerve pain, and with this condition. So really managing this in the acute stage is important, and it should be reinforced. We historically have a very bad rap on, properly medicating patients' pain because it is it's subjective in nature, right? We say on a scale of 0 to 10, like, what is your pain? And we have to take what that patient's tolerance level is for their word. But if you think about nerve pain in general, it is some of the most excruciating pain, because that is literally the physiological element that is sending the impulse to the brain to say that something hurts. And so we need to educate about proper pain management in all of this process. And in terms of bringing caregivers in, we have to help educate and teach them how to support the recovery and prevent secondary complications, right? And those secondary complications could be contractures, and so encouraging range of motion at home, or making them, aware that the potential for these patients to have to go to some sort of skilled nursing or rehab facility after their time in the hospital is very high, because we have to plan for potentially physical or occupational therapy to come in to help these patients regain their strength, mobility, and coordination. And following up with their neurology and rehabilitation services is huge. These are huge components that we need to incorporate into the care of these patients. So Guillain-Barré is fairly simple. Okay, so to sum it up, Guillain-Barré is a rapidly developing autoimmune condition that affects the peripheral nervous system after someone has already been sick with something. And what they are normally already sick with is some sort of upper respiratory infection or gastroenteritis that they get, and they start to sort of battle through, and they start to get better, and then their immune system starts to go on the fritz and starts attacking their nerves. And it starts to demyelinate or damage the sheaths that sit around the nerves, and it causes terrible nerve pain and subsequent paralysis that is ascending in nature. That's a big key, is that it is an ascending sort of assessment pattern that we're looking for, and it can start from the periphery and it starts to move inward and upward. So we see weakness in the legs. It can progress to respiratory failure, and the nursing care for these sorts of patients are really centered around early detection, that respiratory system, and monitoring to ensure that they are not crossing over potentially into some sort of respiratory failure, helping facilitate or bring to light considerations for some sort of immune therapy, whether that is IVIG or plasmapheresis, and really trying to prevent subsequent complications. And those complications fall under two essential categories, right? We've got respiratory complications, and then we've got all of the other potential complications that we're worried about because of their immobility, being DVTs, pressure ulcers, contractures, muscle wasting. So that is everything that I have specific to Guillain-Barré syndrome. Thanks for joining me in this episode. If this has helped you get a clearer sense on what Guillain-Barré syndrome is or how you might go along treating it, pass it along to a friend or, a nursing student that you might know about. And if you have time in your day, please consider, I love reading reviews, especially if they're good. I love getting emails with topics of interest. This topic of interest came from a nursing student by the name of Jessica. And so I was able to put it together even though I'm on the road. Hopefully it was meaningful. And if not, I'm sorry that you've just wasted about 25-ish minutes of your time. But at the end of the day, go forth and keep on learning, my friends. Thanks for listening to this episode. If you've enjoyed what you've heard or enjoyed listening to these episodes, please make sure to rate and leave a review in the platform you're listening to it in. If you'd like to support the show, check out the podcast description for a link to the Nitty Gritty Nurse shop where you can purchase items. This podcast is meant for education and entertainment purposes only and is not meant to serve as medical advice. Please consult a qualified healthcare professional for advice. I strive to provide accuracy, but errors may occur and medications, protocols, and best available evidence may change over time.